Good evening, friends. Welcome to our Tuesday webinar from Yashoda Hospitals, Hyderabad, from the Department of Critical Care Medicine. So we bring forth these sessions almost more than 4 years, around more than 200 webinars been already there in the stream. So today's topic of discussion is the tube went in, but the patient collapsed. Managing the physiological difficult airway. So basically, if you think the ICU, securing airway is not the finish line. So these patients, many of the sickest patients have lot of physiological vulnerabilities. So because of which the difference between a stable post-intubation course and a sudden collapse is all that makes a difference while you are managing the physiological difficult airway. So today we have the expert panelist with us, Professor Sheila Nayan Mantra ma'am. She's a distinguished professor at Tata Memorial Hospital, the Division of Critical Care Medicine. So I think more than 25 years, madam is there. She's the past president of our Indian Society of Critical Care Medicine and even AIDA, the All India Difficult Airway Association. And Madam is the chair of the Intensive and Critical Care Committee of the World Federation of Societies of Anesthesiologists. I think Madam has done a commendable job. She encompasses like the work in hemodynamic monitoring, as everybody know, the tidal volume challenge test, where fluid responsiveness can be looked at, is a pivotal work in hemodynamic monitoring. And other than that, Madam has done. She was there in AIDA during that period, developed guidelines, led the guidelines group for tracheal intubation in the ICU and unanticipated difficult tracheal intubation in adults. I think Madam is serving as a member of Surviving Sepsis Campaign 2025 Guidelines Committee and the Research Committee. So I think she had been the editorial member of the Canadian Journal of Anesthesia, Journal of Critical Care Medicine, many contributions, I think, towards peer-reviewed journals, international collaborations, multicentric studies. I think we can go on, so many accolades in our profile if you just look at this. Really, it's an honor to have you on our platform, ma'am.
Kaladhar, just wanted to probably echo the same. I think we cannot complete her achievements in this period of an hour or so.
Yes, sir.
So, India has been put into the world map on global platforms by her.
Global.
I've seen global faculty quoting her studies, and
Yes.
she brought a lot of transformation in the intensive care medicine, and we all are admirer of her
Yes.
faculty lectures. He was been an academician, core academician, loves teaching, and we all want to enjoy. In new area, I think last a decade or so, this concept of physiological difficult airway came in. We have been all taught to us in our medical school days or post-graduation days of uh, anatomically difficult airways, and more of a anesthesiology or 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 operation theater related difficult airway concepts. Mallampati grading, Corman-Lachman grading, Lemon scoring, difficult anatomical airways, and how do we do. But when it comes to the critical care area, more than anatomical difficult area, the more common challenge is a physiological difficult airway because of the complexity of the patients. I think that probably brought this concept over a decade, and none other than C can be a perfect expert panelist on delivering that talk. We all are looking forward to listen to her. It is our proud privilege to host her in this academic session. Over to you, ma'am. Thank you for being with us.
Yes, sir. I want to introduce you also, sir. 1 minute. So I introduce Dr. Venkatraman Kola, sir, as the chairperson. I think is none other than the mastermind and driving force behind these sessions. I think it contributed immensely to academics in critical care across the India and I can say globally also. So we are privileged to have both of you, ma'am. So
Thank you.
please
Over
continue.
to you, ma'am.
Over to ma'am. Yeah.
Thank you very much. Firstly, I want to thank my dear friend, Dr. Venkat Kola, for inviting me to speak at this very prestigious forum. And thank you, Dr. Kaladhar and Dr. Kola, for facilitating this and for that very kind introduction, Dr. Kaladhar. So I'm going to be speaking on airway management, and this is a subject that's very close to my heart. I have no relevant disclosures other than having a passion for the topic and also being doing a lot of research in this work. Now, if you see the title of the presentation, as you know, has already been said, I'm going to be talking about the physiologically difficult airway. But, the title of this talk is "The Tube Went In, but my patient collapsed." So I want to emphasize a point that we have to think beyond anatomy, right? And whenever we think about airway management, people get stressed because they say, oh my God, I have to technically deliver the tube into the, trachea. And if it is difficult, when we talk about difficulty, we're always talking about anatomical difficulty. Will I be able to do that? Should I give a muscle relaxant? And these kind of thoughts keep coming in our mind, right? But we have to realize that and this is also for anesthesiologists who often think that they are very competent in airway management. But what we don't realize is that these patients have a physiologically difficult airway. So it is not just the anatomy, but beyond that, that we have to worry about. And what I'm going to do in the next 35 to 40 minutes is I'm going to talk about, highlight, the challenges with airway management and with the physiologically difficult airway, and also talking about evidence-based trace strategies and what is the current thinking in this area. So I'm going to be speaking about that in the next 40 minutes, as I mentioned. But just to contextualize this, I'm going to start with the case. So this is a clinical scenario, 57-year-old male with acute hypoxic respiratory failure. He's come to the ICU, his hypoxia is worsening, now he's delirious, uncooperative. He's already on BiPAP, okay, and that is the settings. Saturation is 88 to 92, and respiratory rate is in the 40s. So obviously in this patient, airway examination is not possible. He's tachycardic. If you see the BP, it's 140 by 70. And we don't know the fasting status, and labs are grossly within normal limits. Now in critically ill patients, by default, we do what we call a rapid sequence intubation because we're worried about aspiration. And in this patient, fasting status is not known. So we went ahead, we gave Propofol to this patient, 100 milligrams of Propofol, and rocuronium was given and rapid sequence intubation was done. And it was done using a video laryngoscope, nice grade 1 view. And the endotracheal tube, as you can see the vocal cords has passed through the cords. And we have confirmed this with EtCO2, a nice waveform capnography. So we're very happy because the tube is delivered. Now what next? So we're very happy and we move on to the next patient. And what happens is the next patient's blood pressure is 80 by 40. The end-tidal CO2 drops from 35 to 15. And you give some MEF 25 milligram push or some other vasopressors. Patient becomes pulseless and CPR is initiated, right? Now, of course, it's never so dramatic, but often you see that following tracheal intubation, the patient's blood pressure drops and the patient has precipitous fall in blood pressure. This is not something that we see very often in the operating room. So this patient has what we call a physiologically difficult airway. Now, I want to talk about a bit about airway management in the ICU, and this is a sentinel paper on airway management, and it's called the INTUBE Study, and we published this in JAMA in March 2021. I was very fortunate to be the co-PI on this and the second author of this paper. And what we did is we looked at intubation practices across the globe in critically ill patients, and we looked at what were the rate of complications and how were intubations being done in critically ill patients. Now, this is not something new. There have been many studies. There have been national audits. There have also been multi-center national studies. But this was the first time that we took 29 countries across the globe, and not only the developed world, usually from where papers come, but also the developing world, to know how patients were being intubated and what were the rate of the complications. So if you see, almost 3,000 patient data is what we had, 5 continents, 29 countries. And you can see India, many of your sites maybe have been a participant in this. There were almost 68 sites from India on this paper. So you can see the PIs from Italy, and you can see India has a maximum number of participating among these 3,000 patients. And I'll just give you a little snapshot of the study just to contextualize what the rate of complications are. So what we looked at, and this was a simple observational study, and what we looked at is at least one of the following events occurring within 30 minutes of tracheal intubation. So if they had severe hypoxia or a cardiac arrest or any cardiovascular instability, okay, defined by this criteria, if that happened 30 minutes after intubation, then it was considered as an event for the primary outcome, okay? So I'll just give you the broad data on the outcome. So when we looked at the primary outcome, that was a composite of any of those complications happening, it was 45%. Okay, that means 1 in 2 patients in whom we do a tracheal intubation has one of these complications. And unlike what we imagined, it was not severe hypoxia. You're always worried about patient desaturating and not being able to secure the tube. If you see, the desaturation was only 9.3%, but cardiovascular instability, okay, was 42%, almost close to the total complications, okay? So 1 in 2 patients almost have hypotension or cardiovascular collapse following tracheal intubation, right? So unlike what we imagined, it is not hypoxia. Okay, because probably over time, we are so worried about the patient desaturating that we have become very good at peri-intubation, oxygenation, and hypoxia is not seen as often as hypotension. So the real complication and what this study revealed was that hypotension occurs almost in 1 to 2 patients. Cardiac arrest was somewhere 3.1, and this is consistent with the literature. So this was an important finding from the INTUBE study. As you can see, severe hypoxia was 9.3%. But one of the most important findings of the INTUBE study is that we looked at 28-day mortality, okay? So most of the airway study looked at immediate complications, but we looked at 28-day mortality. And what was a real important eye-opener for us, that if the patient experienced an overall outcome of any of these complications or cardiovascular instability and cardiac arrest, they had a higher risk of 28-day mortality. Now, this is very serious. That means that simple complications that you have, hypotension or hypoxia, you reoxygenate the patient, you give a vasopressor, and you're fine. But if you have one of these events, this actually has a bearing on your 28-day mortality. Now, that means that it's not just important to treat it, but you should actually try to prevent this complication. So, this was a very important finding of this study, that small complication that occurs just after tracheal intubation actually has a bearing on long-term outcome vis-a-vis 28-day mortality. Now, I come from a background of anesthesiology. I do intensive care, but I've often wondered, why are complications related to tracheal intubation in critically ill patients so high, right? So I also work in the operating room sometimes. So I have the opportunity of comparing airway management in the operating room with the intensive care unit in the same period of time. Now, in my mind, there are 3 fundamental differences. Now, the ICU environment is a very complex environment. I'll show you a picture shortly. And this itself increases the risk of complications. Then you have the operator factors, okay? So not all have core competency of airway management. You have different multidisciplinary, people from different specialties and different levels of skills. So the operator factor makes a big importance in airway management. Not all are the skilled airway operators. As for anesthesiologists, airway management is a core competency, right? So you have wide variation in this level of the skill of the airway operator, which has a big impact on the complications. And most importantly is the patient. This is not the stable, fasted, optimized patient who comes for surgery. This patient has critical illness and has what we call a physiologically difficult airway. Now, this is an old photograph of mine, intubating, trying to intubate a patient. Now, this maybe, is in the night. I have my other trainee is, looking after another patient. Now, this is a patient of septic shock. So I not only have to manage the airway, I also have to manage the hemodynamics. I just have a male nurse with me who's helping me push some drugs. So just look at the environment, okay? Just getting to the head end of the bed is such a struggle in the intensive care unit. For those of you who've been in the operating room, this is not the case. There's a ventilator, my ultrasound machine, crash cart, everything's around. There's so much clutter. This is any time in the day or night. I don't have all the tools in my armamentarium. I don't have my video laryngoscope. I don't have my bronchoscope. I don't have all the advanced airway equipment with me. So the ICU environment is so complex that this complexity itself increases the risk of complications during tracheal intubation, right? And as I mentioned, not only the skill of the operator, but the patient is the most important factor. And these patients often have an imbalance between oxygen delivery and consumption. And you know that they're critically ill. So often there are various factors, fever, sepsis, tachypnea, etc., that can increase the consumption, and many factors that can decrease the DO2. And we're familiar with that. Patient may be anemic, low cardiac output, lung disease, low FRC. So we already start at a disadvantage with these patients. And we have to understand that they have a very short apnea time for this reason. And this is why we have to hurry with the intubation. So these patients have what we call a physiologically difficult airway. Now, this is not something new. This has been there for generations. It's just that this got recognition and people started talking about it. And this was first described in 2015. Okay, so less than 10 years ago by John Sackles and Gerard Mosier, who came from the emergency department. And they highlighted this entity called physiologically difficult airway. And they said, stop just talking about anatomy. These critically ill patients have a physiologically difficult airway. Now, they talked only about critically ill patient, but, we looked at the definitions and we said, the physiologically difficult airway is still an emerging entity. And along with Dr. Devatia, we wrote this in current opinion in anesthesiology. And we said, we need to expand the definition of what is a physiologically difficult airway. And we also need to have consensus on how to manage this airway. And this is what we wrote in this review article in current opinion. And this is what we came out with last year. And I would like to share this paper with you. And this is tracheal intubation in the critically ill with a physiologically difficult airway, an international Delphi study. Now, this was published in Intensive Care Medicine in October 2024. And what we did in this is we took international experts in airway management, in critically ill patients, and we got them together and we conducted a global Delphi to get consensus on how to manage these patients, right? Because there isn't very good evidence, for various interventions for tracheal intubation in critically ill patients. So when that is lacking, the next best thing that you can do is to do a Delphi. So it was a very robust procedure. The experts didn't know each other till the end of the procedure. They were blinded to avoid any bias or any kind of group pressure. And we had a separate steering committee and separate experts, and we had iterative rounds. And it was not only consensus, but we also had to achieve stability between the rounds. So when there was stability in the responses between the two rounds, that was when we removed the statement and considered it as consensus. So it was a really robust process that we followed. And I really urge you to read this paper because everything is very beautifully summarized in the expert consensus statements that was generated from this Delphi process, right from the definition of what a physiologically difficult airway is, how you should prepare your team, how you should prepare your patient, how to perform the procedure, and also post-intubation care is very nicely summarized and described in it. And what I'm going to do in the next 30 minutes is give you a snapshot of this, but I really urge you to read the paper because especially those who are exam going, because if you just read this paper, you will have all the information that you need to understand airway management in critically ill patients. And also you will have all the updated references. So I'm happy to share this with you. So coming to the definition, and we said a physiologically difficult airway is one in which the patient's physiological and pathophysiological, okay? So it's not just the pathophysiological like you see in critical illness, but even, people who are obese and obstetric patients, even they have altered physiology and they also have increased risk of complications because they have reduced FRC, they have a short apnea time, they rapidly desaturate, after you give a muscle relaxant for tracheal intubation. So these are the patients that we said, and these are likely, pathophysiological alterations we see in critically ill patients like hypoxia, cardiovascular instability, right ventricular failure, increased intracranial pressure, right? And these patients are likely to be seen in the emergency department and the intensive care unit. And there are a lot of human factor considerations also when you conduct airway management in these patients. So what we summarize physiologically difficult airway by consensus is we're talking about the pathophysiological alterations like you see in critical illness, hypoxia, cardiovascular instability, right ventricular dysfunction, and increased intracranial pressure. For example, if you have the patient with, brain injured patient with a raised ICP and you try to do a tracheal intubation in that, you can actually cause neurological complications in this patient, right? So this is why this patient has a physiologically difficult airway, and it's not about just putting the tube in, but there are a lot of precautions that you have to take while intubating these patients. And also physiological alterations, like you see in obesity and pregnancy. So what we did is we expanded the definition to include physiological and pathophysiological alterations. And this is what we meant by that. Now I'll give a little overview on performing the procedure. Okay, so and the preparation related to that. Now, what we do in the intensive care unit, we do a modified rapid sequence intubation. We don't do the classic rapid sequence intubation anymore. Now, why do we do a rapid sequence intubation, right? Now, rapid sequence intubation is essentially to prevent aspiration. So what happens is that critically ill patients have, either they may be full stomach, they must have had a whole meal and they will come in acute hypoxia, respiratory failure, you have to intubate them. So that's why they need a rapid sequence intubation. Or you also have the gastroparesis of critical illness, right? So by default, critically ill patients are considered as full stomach. They may be diabetic or other conditions that slow the gastric emptying. So by default, we do a rapid sequence intubation in these patients. Now, when we say modified rapid sequence intubation, what do we mean? That you give the titrated administration of rapid onset of sedative hypnotic drugs. You give a rapidly acting neuromuscular blocking agent. We also consider gentle mask ventilation in these patients during the apnea, and I'll come to talk about that in a bit. And this is to prevent the peri-intubation complications. Now, why do we do an RSI? So in the RSI, the basic principle is that you are worried about aspiration, right? So you have to shorten the time between when the patient becomes unconscious and the time when the tube goes in with the cuff inflated so that the patient can't aspirate. So this time has to be shortened. That is why it's called a rapid sequence intubation or induction. And for this reason, you need very rapidly acting muscle relaxant like suxamethonium or rocuronium. You can't have long acting muscle relaxant because then it beats the purpose of doing an RSI, right? And cricoid pressure is a little controversial, but if you are applying that, then remember you should release it if you have any difficulty in visualizing the cord or even in passage of the tube, and that was the consensus statement. So RSI should be the default, and we use rapidly acting neuromuscular blockade in these patients. Now, positioning is very, very important. Okay, we rush to intubate, but if you don't position the patient well, okay, this is bad anatomically to deliver the tube and also physiologically for the patient. Now, if you see a patient who comes to you in acute hypoxemic respiratory failure, if they come in the trolley, you are trying to make them lie flat, they are sitting up. Again, they're sitting up. This is the patient position in which the patient is comfortable. They are not comfortable in flat position, and yet we try to make them flat because we want to intubate them, right? So it's good to give them a little 20-degree head up position. And also, in the flat position, the posterior portions of the lung become very prone to atelectasis and collapse. So the position that you should give them is a 20-degree head up position, or what we call the HELP position, head elevated laryngoscopic position. So about 20-degree head elevation for pre-oxygenation as well as for tracheal intubation. And as I mentioned, it's also the patient position in which the patient is more comfortable. You can make the face absolutely parallel to the ceiling. And this is especially useful in obese patients, where you can, the tragus should be at the level of the suprasternal notch. Okay, and if that is not the case, you can ramp up with a few pillows, but this will help you align the three axes and make tracheal intubation much more easier technically to do, because positioning makes a lot of difference. Okay, so especially in obese patients, you can put some folded sheets or blankets or whatever to align the tragus with the suprasternal notch. Okay, and that will make it easy. But remember this position, face parallel to the ceiling and ear level with the suprasternal notch and a 20-degree elevation. And then we call this the HELP position. Okay, or the semi-Fowler's position also is what it is called. Now, the pre-oxygenation is really, really important. We've already talked about what high-risk patients these are. They are prone to hypoxia. So pre-oxygenation, and not only pre-oxygenation, but we have the concept of apneic oxygenation. That means you give oxygen, nasal oxygen during attempts at intubation. When the patient is not breathing, you still give apneic oxygenation. And what this apneic oxygenation does is it can prolong the safe apnea time. What do we mean by safe apnea time? That is the time from which you give the muscle relaxant to the time the patient desaturates. Now, these patients already have lung pathology, ARDS, whatever. So they're critical, their reserve is very less. They desaturate very fast. If you pre-oxygenate well, then they will take more time to desaturate. And if you give them apneic oxygenation, it can further prolong the safe apnea time, right? So you should make every attempt to pre-oxygenate and give apneic oxygenation to this high-risk group of patients. But having said this, remember one thing, that unlike normal patients, critically ill patients, the response to oxygenation may not be as good as in the normal patients, okay? So you might give oxygen, and this has been shown in cardiac surgical patients. What they've done is they've taken patients from cardiac surgery and critically ill patients, and they've given them the same oxygenation strategy, and they've done blood gases, and they've seen that the oxygenation after 3 minutes was far superior in those patients who had, who were cardiac surgical patients with normal lung as compared to critically ill patients, right? So remember, the response to pre-oxygenation may not be as good. Nevertheless, every attempt at pre-oxygenation and apneic oxygenation should be continued. Now, what are the tools that we have in our armamentarium? So we have the conventional face mask, and we have two advanced, relatively new technologies. We have high-flow nasal oxygen. Okay, a lot of people say high-flow nasal cannula, but remember the therapy is high-flow nasal oxygen. So when you're giving high-flow nasal oxygen, and if the patient can keep the mouth closed, you're actually also giving PEEP to this patient. And NIV, you already know, you have, you can have a separate NIV machine, or you have the ventilator with the circuit. You're already going to intubate and hook the patient up on the ventilator. So you can use the same circuit and the mask, and you can put the patient on pressure support and PEEP. So he's spontaneously breathing, and you can give more definite delivery of PEEP. So these are the little better modalities where you can give some PEEP to these patients. So how do they fare? Which one is better? Now, this is a study which compared, and this is a landmark study that came last year, NEJM again, where NIV was ventilation was compared for pre-oxygenation with conventional oxygen therapy. And one would think, oh my God, you really need a study to compare conventional oxygen therapy with NIV. Obviously, NIV will be better. Well, no one had studied it in a randomized controlled trial, and this is why it came into NEJM. 1,300 patients, NIV versus COT, which is conventional oxygen therapy. That is your usual ambu bag and mask, or just your regular oxygen mask. And the primary outcome was hypoxia during intubation. And you can see 9% and 18%. So clearly NIV was superior for pre-oxygenation in patients during tracheal intubation. Okay, so this is NIV versus oxygen therapy. But how about NIV versus high flow nasal oxygen, right? So these are the two modalities that we currently use. Which one is better? So this is a Florali 2 study, and it's a French multicentric study where they tried to compare, they did whether this NIV given for pre-oxygenation or high flow nasal oxygen given for pre-oxygenation and continued during attempts at, intubation was superior. And their primary endpoint was saturation falling less than 80% during tracheal intubation. They had about, interestingly, if you look at the primary endpoint, there was no difference in the p-value, right? But in the subgroup of patients who had PaO2 FiO2 ratio less than 200, NIV was more superior, probably because of a more definitive delivery of PEEP. So the message from this is that patients who have moderate to severe hypoxia, P2F ratio less than 200, NIV may be more superior, and that was the inference from this study. But now we have, in 2025, we have the meta-analysis, which was published in Lancet Respiratory Medicine, comparing all the pre-oxygenation strategies, all the studies looking at different types of pre-oxygenation, whether it was high flow nasal oxygen, conventional oxygen therapy, or whatever. Comparing any study that compared to modality was included in this. And there were 15 eligible patients and 3,400 close to 3,500 patients, and this was led by the group from Bram Rochefort from Canada. And what was really interesting and what they found, and this was a systematic review and network meta-analysis, and here you can see you can see high flow nasal oxygen, NIV, and even combination therapies were looked at, but very few studies, and you can see there's a clear, movement towards the high flow nasal oxygen and NIV. And what they found was that pre-oxygenation, they concluded that pre-oxygenation with NIV or high flow nasal oxygen rather than conventional oxygen might prevent hypoxia during tracheal intubation in adults who are critically ill. And what they found that compared to high flow nasal oxygen, non-invasive positive pressure ventilation probably decreases the incidence of hypoxia. So their findings actually should inform guidelines. So what they showed clearly, the conventional oxygen therapy is not beneficial in these patients, and we need to use a more advanced form of oxygenation in the form of either hyponasal oxygen or non-invasive ventilation. And we wrote I had reviewed the paper and I wrote the editorial for this paper with Samir Jaber from France, and we titled it Pre-oxygenation for Tracheal Intubation in Adults Who Are Critically Ill, Time to Abandon the Face Mask. And the reason we gave this title is that clearly in critically ill patients, we should not use conventional oxygen therapy for pre-oxygenation, and we need to use NIV or high flow nasal oxygen, a little more advanced pre-oxygenation and modalities that can actually give PEEP to these patients. What about bag mask ventilation I talked about during RSI? As I told you, these patients have, are considered by default for RSI because there's a perceived risk of aspiration. Now, what happens is that these patients, are at, we do RSI, and during RSI, we never give bag mask ventilation because obviously you can cause gastric insufflation and patient can aspirate, right? Until the tube is put in. But at the same time, these patients are at a high risk for desaturation, right? You have patients with pneumonia, ARDS, they are at a high risk for desaturation, right? So if you don't ventilate them during RSI, you have the risk of, critical desaturation, arrhythmias, and all that happening. So this group actually did something very brave. They did a rapid sequence intubation. In one group, they did, conventional rapid sequence intubation with no ventilation during apnea. And in the other group, they did gentle bag mask ventilation. And they involved only those patients who are not at a high risk of aspiration, but at a high risk of desaturation. Now, what did they find? And then the primary endpoint was the lowest oxygen saturation. And as you can see that in those patients who got mask ventilation, obviously the oxygen saturation was, much better than those who didn't get the ventilation. And that was not surprising. It was significantly better. And this study was actually criticized a lot because, it was not powered for aspiration. But there was no increased risk of aspiration in those patients who got mask ventilation. So taken together, I would say that, this study gives us a confidence that in those patients who are at a high risk of desaturation, but not at a high risk for aspiration. I'm not talking about somebody who's had a full meal and come. So who's not at a high risk of aspiration, it gives you confidence that you can do gentle mask ventilation and avoid the desaturation that happens. And this has been incorporated now in the guidelines. So we use gentle mask ventilation in these patients. Now I'm going to talk to you about another entity called rapid delayed sequence intubation. This might be a new terminology for some people. We've talked about rapid sequence intubation, but what is delayed sequence intubation? Now, delayed sequence intubation comes from, again, the emergency department, and it comes from the group of Scott Weingart, who first talked about it. Now, delayed sequence intubation is a way of facilitating pre-oxygenation in patients who are very rowdy and very hypoxic. So sometimes you see these patients who come to the ED or to the ICU, they are very hypoxic and they're very rowdy. So you can't pre-oxygenate them. You put the mask on their face, they throw away the mask. You put the mask on their face, they start pushing you away. So these are the patients who need pre-oxygenation the most, but it's really difficult to pre-oxygenate them. So delayed sequence intubation is a technique by which you can give ketamine, small doses of ketamine, 1 milligram per kg of ketamine is given to these patients. And when you give this, and the beauty of ketamine is it doesn't produce any respiratory depression, unlike, your midazolam or benzodiazepines or opioids or etc. So it's very safe because you can keep the patient spontaneously breathing, and at the same time you can calm them down. So once you give them, say, 50 milligram of ketamine or 1 milligram per kg of ketamine, they become very calm. You can make them lie flat. You can pre-oxygenate them well. So you don't just rush to intubate them as you would do if you're not able to pre-oxygenate them. So you give them good pre-oxygenation. I've started using this technique a lot. And, I've actually noticed that you don't have to intubate many of the patients. Many of these patients who come to you, the way they present, you think, oh my God, I need to intubate this patient right away. But I have seen after using delayed sequence intubation and pre-oxygenating them well, many of them actually don't need intubation. And of course, you may proceed to do a rapid sequence intubation thereafter. Or even if you want to do an awake intubation using a bronchoscope, this ketamine really facilitates the procedure. So essentially, delayed sequence intubation is nothing but a technique to facilitate pre-oxygenation in those patients who are rowdy and hypoxic. But Scott Weingart, discovered it, but it was never tested in a randomized controlled trial. And I'm very proud that the first randomized controlled trial testing delayed sequence intubation with just a rapid sequence intubation comes from PGI Chandigarh. And this was a study that was published in Anesthesia and Analgesia. And what they did in one group, they did just the delayed sequence intubation, and the other one, they did the rapid sequence intubation without the pre-oxygenation in these patients. And what they found at all time points, you can see significantly improved oxygen saturation in these patients was much better in these patients. So remember, the next time you have a patient who comes very rowdy and hypoxic, remember to give them a sleep dose of ketamine, calm them down and pre-oxygenate them well, and don't rush to just intubate them. So in summary, if I'm talking about the oxygenation and the respiratory optimization of these patients, is you pre-oxygenate with either NIV, that is pressure support with PEEP, if available, or you can use high flow nasal oxygen. But NIV is better in patients who have moderate to severe hypoxia. Apneic oxygenation, continue nasal oxygen during attempts at securing a tube. Even if you're not using high flow nasal oxygen, you can use a simple nasal cannula, but give oxygen during intubation. Gentle mask ventilation, especially in those patients who are at a high risk of desaturation and not at a high risk of aspiration. And in patients with physiologically difficult airway who are difficult to pre-oxygenate due to lack of cooperation, you can consider the delayed sequence intubation using ketamine. So we talked about respiratory optimization, and remember, the important message in a physiologically difficult airway is not to rush to intubate, but to optimize the patient to minimize the risk of complications. Physiological optimization, both respiratory and cardiovascular, are very important. So I've talked about respiratory optimization and the summary of that. I'll just move very quickly to cardiovascular optimization. Now, why do patients, we saw 42% of the patients have hypotension, have cardiovascular collapse. Why? Why is this incidence so? What causes hypotension in these patients? So there are many contributing factors, and this is a nice, cartoon that I had made for this review that we wrote in Anesthesia, Critical Care, and Pain Medicine. So contributing factors is the critical illness itself. Okay, you have sepsis, hypovolemia, vasoplasia, cardiac dysfunction. All of this can cause, cardiovascular collapse. The drugs that we use for tracheal intubation, now be very careful: propofol, benzodiazepine, opioids. The loss of sympathetic drive. Now, this is really important. Okay, you remember our patient who came had a 140/80 blood pressure. The blood pressure is fine. So often in these patients who present in acute hypoxemic respiratory failure, it is the sympathetic drive that keeps their blood pressure up. Okay, so they come tachycardic, hypertensive, and you say, oh, the blood pressure is okay, so I can give propofol to this patient. But the moment you anesthetize them for tracheal intubation, they lose that sympathetic drive and they have precipitous fall in the blood pressure. Okay, so be very careful about this. I'll tell you my own approach. I used to always think, okay, the blood pressure is fine, so I would give propofol. If the blood pressure was, low, then obviously I would use ketamine or etomidate. Okay. So the other thing is the positive pressure ventilation. Now remember that when you intubate a patient and you give positive pressure ventilation, soon after that you see the hypotension, right? Immediately after tracheal intubation, within 2 to 3 minutes you see the hypotension. And this in patients who are hypovolemic, intravascularly depleted, your positive pressure ventilation increases the intrathoracic pressure, reduces the venous return, and further decreases the cardiac output, and then you have cardiovascular. These are the various factors that cause cardiovascular collapse, and it is not just one factor, but this is often multiple factors that are involved, and there are potential solutions that I'm going to be talking about. But most important is the drugs. Now, drugs are very important. So we use relatively cardiostable drugs like ketamine and etomidate, okay, which maintain the hemodynamics. Now, about 20 years back, there was a paper in Lancet that compared these two drugs and showed that they were safe to use in patients who were critically ill for tracheal intubation. Subsequently, there have been many papers comparing these, and we have now meta-analysis. This is a most recent meta-analysis comparing ketamine versus etomidate. It's a Bayesian meta-analysis. And here they found a moderate probability that induction with ketamine compared to etomidate for tracheal intubation was associated with improved survival in critically ill patients. Well, no conclusive evidence that one is better than the other. It's good news for us because ketamine is relatively cheap in India and also available in many parts of the world where I speak. Ketamine is not even available. So you can use, the message really is you can use ketamine or etomidate, but you must use something like these drugs, which is relatively cardiostable rather than something that can cause hypotension. Now, going back to the INTUBE study, what we did is we did, analysis of all those patients who had cardiovascular collapse, okay? And we published this in the Blue Journal, in the American Journal of Respiratory Critical Care Medicine. What we did, we took all those 42% who had cardiovascular collapse and we did a multivariate analysis and we tried to understand what were the reasons why these patients had hypotension. And what is very interesting is that we found that the use of propofol, okay, as you can see, was an independent, identified as a modifiable intervention significantly associated with cardiovascular collapse. So it was a modifiable intervention. So what we found is that propofol actually was the offender. And what was more interesting in this is we found that irrespective of the starting blood pressure, propofol independently transitioned to hypotension. Okay, so, like I said, often we think that, oh, the blood pressure is fine, I can use propofol. And this was also my practice. But we have to be very careful because it's often the sympathetic drive that keeps the blood pressure up. So the real message from this paper is that try to avoid using propofol in these patients and use more cardiostable drugs like, what I mentioned is ketamine and etomidate in these patients. Now, what about, giving a fluid bolus? Now, we know that it is well known, not only the INTUBE study, but from other studies also, we know that hypotension occurs in these patients. So if you look at the intubation bundle that was proposed by Sameer Jaber, they talked about giving a fluid bolus. Give a fluid bolus before tracheal intubation, right? But that was commonly our practice. Give 500 ml of saline before you do tracheal intubation so that there's no hypotension. But this had never been tested in a randomized controlled trial. And this is what the group from Vanderbilt did, led by Jans. What they did is they did a randomized controlled trial, 337 patients. And what they did is in one group, they gave 500 ml of saline prior to tracheal intubation. And in the other group, they gave no fluid bolus. And they looked at cardiovascular collapse incidence. Now, what was very interesting is that this common practice of ours of giving the fluid bolus before doing tracheal intubation, actually, there was no difference. So administration of intravenous fluid bolus did not decrease the overall incidence of cardiovascular collapse compared to no fluid bolus, okay? So that was really surprising because the first time it was tested in a randomized controlled trial, and that's why it got published in Lancet, obviously. And interestingly, in this study, in the subgroup of patients who had received positive pressure ventilation, that means either they got NIV for pre-oxygenation or they got gentle mask ventilation during RSI, in those patients, fluid bolus seemed to make a difference. So what this group did is they prepare group, the same group from Vanderbilt, they did the Prepare-2 study. And what they did in the Prepare-2 study is they took only those patients in whom positive pressure ventilation was given. That is either NIV or high flow nasal oxygen or RSI. They took only those patients and in them they gave either 500 ml of saline or they gave no fluid bolus. Okay, so almost this is a larger number of patients, almost 1,000 plus patients. And what they found, no difference in the incidence of cardiovascular collapse, whether you gave a fluid bolus or not. Now, this really puts you in a dilemma because when tested in a random, of course, there were a lot of limitations in these studies, and I cannot talk about that in the interest of time. But when tested in a randomized controlled trial, it's actually showed that fluid bolus prior to tracheal intubation doesn't seem to be making a difference on the incidence of cardiovascular collapse. So cardiovascular collapse is real, 42%. A fluid bolus doesn't seem to be making a difference. So perhaps there is a role of giving a low dose of vasopressor prior to tracheal intubation to prevent rather than to treat. We just rush to treat the hypotension, but we should probably try to prevent this. And now there are 2 trials underway, and one has just been completed at the Tata Memorial Hospital, and I'm really proud to lead this. I'm still not convinced that fluids don't make a difference. So here, this is a randomized controlled trial. We're calling it FLUA trial, comparing the effects of a fluid bolus along with a low dose of vasopressor. And we're looking at this prior to tracheal intubation and looking at the incidence of cardiovascular collapse. And when we say vasopressor, we're using norepinephrine, and the dose is 0.08 microgram per kg per minute. Started as an infusion, and of course, we don't have a central line for all patients, so it was given through the peripheral line. And the reason we start 10 minutes prior is because it takes at least 10 minutes for this drug to start acting. It's a very low dose. And then it's continued up to 5 minutes after tracheal intubation, which is when most of the hypotension occurs. Now, we have to be very careful. We couldn't give very high doses because, there's also the pressor response of laryngoscopy, which can increase the blood pressure, right? So we've completed this trial, and we're just going to very shortly publish the results. And there's another trial called the prevention trial, and this is in Europe, and this is a multi-center trial. I'm also on the steering committee of this. And this is looking at a low dose of norepinephrine versus usual care. So the results of these 2 trials, and this is a very important unanswered question in airway management in the physiologically difficult airway, will actually tell us whether there is a role of the preemptive use of vasopressor to prevent this high risk, high incidence of complications that occur. And so probably we'll have the answer in 2026, whether there is a role of giving the low dose of vasopressors. The summary of the drugs for rapid sequence intubation, talking about the hemodynamic, was ketamine or etomidate, and standard anesthetic dose of propofol should be avoided. And a lot of people have concerns about ketamine, but ketamine has been proven to be safe. What about the muscle relaxant? Like you mentioned, for a rapid sequence intubation, you need short-acting muscle relaxants. So people have concerns about using scoline. So unless contraindicated, okay, there are contraindications, and specific contraindications in the critically ill. So if there are no contraindications, randomized controlled trial have shown no difference between scoline or rocuronium, and they should be preferred for giving the neuromuscular blockade, not long-acting muscle relaxants. And saxamethasone, as mentioned, should be avoided in certain situations, and you know what these situations are. And remember one thing, when you're using rocuronium, if you like to use rocuronium, you have to give much higher doses when you're doing an RSI. You should give at least 1.2 milligram per kg. Okay, because only if you give this high dose will you get intubating conditions in 60 seconds. Otherwise, it beats the purpose of using rocuronium for rapid sequence intubation. Okay, so keep that in mind, at least 1.2 milligram per kg. Hemodynamic monitoring is very important. Okay, now you don't have lines in, so a big role for the use of ultrasound. And minimum mandatory monitoring should at least be a non-invasive blood pressure monitoring, at least ECG, pulse oximeter. I hope you're attaching this before you intubate the patient. And quickly, you can do an echocardiographic assessment. You can have a quick look at what is the preload, what is the contractility, what is the afterload, and this can help you optimize the hemodynamics before airway management. Like I mentioned, it is about respiratory and hemodynamic optimization prior to managing a physiologically difficult airway. Now, what about the tools? I'll go through this very quickly. Now, we looked at the data on the video laryngoscopy. Unfortunately, only 17% were using video laryngoscope, but still we had 500 plus data. Now, unfortunately, video laryngoscopes were not used much in the critically ill community. And the reason because people were not familiar with it, it's more used by anesthesiologists. And also because the data with video laryngoscopy, whatever the 9 randomized controlled trials in a meta-analysis, didn't show any improvement in first-pass intubation success when a video laryngoscope was used. And this is probably also one of the reasons why it was not very popular. But when we looked at the data from the INTUBE study, okay, about 500 patients, it was the first time that we found that there was increased first-pass intubation success, okay, in patients in whom a video laryngoscope was used. Of course, this was an observational study, not a randomized controlled trial. But these findings support the use of a video laryngoscope. And then, of course, you have the device trial that really nailed it, which clearly showed that using a video laryngoscope compared to using a direct laryngoscope increases first-pass intubation success. And the important message from this paper is every ICU should have a video laryngoscope. Every intensivist should be trained to use a video laryngoscope. And this should be the default tool to increase first-pass, to be used for tracheal intubation to increase first-pass intubation success, because the results of this trial clearly nailed it and showed that video laryngoscope is superior to direct laryngoscope. And more important than just increasing first pass success, when you use a video laryngoscope, right? And the other, your assistant can also see the view. So it really is about teamwork. It changes the view from me to we. And you can, guide. If I'm, my junior colleague is intubating, I can guide them. I can say, okay, do this, whatever. So it really becomes a teamwork and makes the intubation not only increases first pass success, but from a human factor perspective and also from an assistance perspective, guidance perspective, education perspective, video laryngoscope really has many advantages beyond using first pass intubation success. And for those of you who are not using it, I would urge you to start using a video laryngoscope. Don't use it when you have a difficult airway. Use it routinely so that you can have it ready also when you have a difficult airway. Now, what about other tools like a stylet and bougie? And this is a study from Samir Jaber from France, 999 patient randomized controlled trial. What they did is they used a stylet during the first attempt of intubation. So in one group, they used the endotracheal tube without the stylet, and in the other group, they used the endotracheal tube with the stylet in the first attempt. Now, usually you use a stylet when you have a very anterior larynx, and you can't pass the tube, then you put a stylet in the tube and the second attempt. But what he did is he used it during the first attempt at tracheal intubation, and you can see significantly higher first pass intubation success when a tracheal tube was used with a stylet. Now, what about a bougie? Now, again, the group from Vanderbilt, they compared a bougie and a stylet, again used during the first attempt at tracheal intubation. They didn't find any difference. They looked at successful first pass intubation success. They didn't find any difference between the bougie or the stylet when used for first pass intubation. But remember, in both these studies, the bougie and the stylet were used during the first attempt at intubation and not as a rescue after failure in the first attempt and the second attempt. Okay, so taken together, these studies actually tell you that a stylet or a bougie should be used during the first attempt at tracheal intubation in critically ill patient to improve first pass intubation success, as these studies have shown you. So if I summarize the tools for tracheal intubation, I would say a video laryngoscopy should be available during tracheal intubation in patients with a physiologically difficult airway. All operators should be trained to use it. Video laryngoscopy should be routinely employed during the first attempt during physiologically difficult airway patients, improves glottic visualization, superior to direct laryngoscopy, aids supervision, as I mentioned, assistance of the airway operator, and most importantly, a stylet or a bougie, whichever one you're familiar with, not one has been shown superior to the other, should be used routinely while performing tracheal intubation, especially when you're using a video laryngoscope. So this is a summary of the tools for tracheal intubation. And the last part I'm going to talk about is about esophageal intubation. Now, this is really important. Now, if you have an esophageal intubation in a critically ill patient, even a single episode, 51% hypoxia. This is an old study from Mott. And if you see esophageal intubation in blue and no esophageal intubation, and if you can see any of the complication, hypoxia, aspiration, bradycardia, how significantly it is different, in a patient with or without an esophageal intubation. So, and those of you who are anesthesiologists will know that sometimes your tube goes in the esophagus when a very junior trainee is intubating, and then we take out the tube, we reoxygenate the patient, no problem, and ask the person to intubate again. In a critically ill patient, this is not at all well tolerated, and there is a risk of hypoxia 11-fold. If a second episode is almost 85%. So the important message in this is that use capnography to exclude esophageal intubation. After every tracheal intubation, you should use capnography. And we had the National Audit Project, which was done, NAP4, which some of you may be familiar with, which was done in the UK, which looked at complications related to tracheal intubation in the operating room and outside the operating room. Now, when you look at the sub-data of those patients out in the critically ill area, 70% of them, had increased morbidity and mortality because of not using capnography. Now, this study was done 10 years ago, and even 10 years later, very few ICUs are using capnography. So really important. And we have had a lot of deaths because of missed esophageal intubation. Okay, so look at this graphic. Is the endotracheal tube in the trachea? So when you're looking at it like this, okay, for instance, this one, do you think it's in the trachea? It give you the impression that it's in the trachea. Always people say, look at the tube going directly through the vocal cords. And you also have something called glottic impersonation. And this often happens when you give a lot of force during tracheal intubation, okay? So you can get the esophageal opening can, it can actually mimic the vocal cords, okay? And there are a lot of human factor considerations when you're in that stress environment, and you can actually believe that you are passing the tube through the vocal cords, okay? So just relying only on your view of the tube going through the cords, because you also hallucinate sometimes. You say, that's what you want. You want the tube to go to the trachea, and you believe the tube is going into the trachea and passing through the vocal cords. Okay, so that is why very, very important to use capnography. And because of 2 recent deaths in the UK and in Australia, of course, there must be many deaths across the world, but maybe they're not reported. We came up with this guideline for preventing unrecognized esophageal intubation, and this is a consensus from the Project for Universal Management of Airways, and this was international consensus, which was published in Anesthesia. And I'll show you the graphic from that, which is really, really important. And whatever you see is green, and what we should follow. So we should use waveform capnography. And of course, you see the square boxes of the consistent waveform. And what is important is not just to look at one trace, but the recommendation is to you look at 7 traces, okay? You should have 7 traces of consistent waveform capnography with no decline, right? So you can see here it is rising. This is all acceptable, but something like this is not. You see waveform capnography and you see it's declining. So this is not, this criteria are not satisfied. Okay, and then you should, the reading should be clinically appropriate. Now, why not the red? I'll tell you, a situation like this, and why it is important to look at 7 waveform, because often when you have a very stormy intubation, very difficult intubation, you're ventilating, a lot of air goes into the stomach. Now you do an esophageal intubation, and when you ventilate this patient, the first 2 or 3 breaths, you'll see this kind of, air will come into the, you will get a capnography trace, but this will decline, gradually decline. And this is the reason why never respond to 1 trace of the capnography, but look for 7 traces of consistent waveform capnography with no decline before you declare that the tube is in the right place. Remember, auscultation is to confirm the position of the tube within the trachea. But capnography is the gold standard to confirm that the tube is in the trachea and not in the esophagus. Now, again, going back to the INTUBE study, you will see that here, some very interesting data. If you look at video laryngoscopy, as I mentioned, only 17% of people in the world are using video laryngoscopy, okay? Now, this was, of course, before the device trial. So maybe after the device trial, more people have started using it. More people have started using it, of course, after COVID. And this was not data from the developing world. This was also from the developed world. So very few are using video laryngoscopy. So it's a big message that we should move to video laryngoscopy if we want to increase first pass intubation success and reduce the complications related to tracheal intubation. The other very surprise finding was that almost 60% of the world is still auscultating to confirm that the tube is in the trachea. Only 1 in 4 of the intensivists is actually using capnography to confirm tracheal intubation. And again, this is not data from the developing world where you can say that, okay, people don't have capnography or don't have video laryngoscopy. So we really have a long way to go to change our practices to improve the utility of these tools, make video laryngoscope be available, make waveform capnography available, and make sure we use it during every episode of tracheal intubation. Okay, so I'll end my presentation with this message that the physiologically difficult airway, as I mentioned, by definition, is one in which pathophysiological and physiological alterations in patients increase the risk of complications during tracheal intubation and transition to positive pressure ventilation. And remember, hypotension and hypoxia are the most common complications, but hypotension is even more common, and we should be very cognizant about this, that 1 in 2 patient is going to have hypotension after you do tracheal intubation. So there is a higher mortality in 28-day mortality if you have experienced these complications, and therefore we should make every attempt to prevent rather than to just treat these complications. And the strategies that I've outlined may help in the safer management of these patients with a physiologically different airway. They are evidence-based, and they are also expert consensus opinion, which is the next best thing derived through a robust Delphi process. And most importantly, remember that tracheal intubation is a life-saving procedure. But this can turn into a life-threatening situation if it is not managed properly. So if you don't do your physiological observations, you just rush to intubate the patient because the patient needs a tube, you might actually land up with a cardiac arrest like we saw in the first case. And, you can actually make it a life-threatening situation. And with that, I thank you very much for your attention. And this is a very nice graphic from our paper in intensive care medicine, which summarizes all the interventions. But I really urge you to read the paper, and I'm going to leave it with Dr. Kola. And with that, I thank you very much for your attention. Thank you.
Thank you.
Questions?
Yes, ma'am. Thank you very much for that outstanding, I think, deeply insightful session, ma'am. I think you broke it down into very practical, simple steps where we can directly take into our bedside practice. With that, I think there are few questions, ma'am. Like I think everything is been clearly told by ma'am. One case scenario, probably if I practically see, where a patient coming with shock with severe metabolic acidosis with a pH of less than 7. This is the common scenario where most of the juniors, because the patient might be by that time hyperventilating to wash out his CO2 to compensate for the severe metabolic acidosis. What do you is your the recommended way of tackling these patients when you are going to intubate?
Right. I'm glad you asked this question, and this is really very relevant. And this is really highlighting the point what you said, the physiologically difficult airway. People rush to intubate this patient. Now, if you do this without optimization, the patient is compensating, okay, with hyperventilating, and then you knock off his, if this thing is respiratory drive, intubate him, and then you have the complications, right? So this is the reason why you try to optimize, you give the fluid boluses, you try to, whatever is the cause of the metabolic acidosis, you try to optimize that, and you also take precautions to prevent that situation. And even after you intubate the patient, you have to be very careful with your respiratory rate. How you're ventilating the patient is also extremely important, because you are paralyzing this patient, right? So the important message is, don't rush to intubate. Respiratory and physiological optimization first whenever feasible. Of course, sometimes you have no option, the patient has a cardiac arrest, you just have to intubate the patient. That's a different situation. But we rush to intubate thinking, oh, critically ill, let's intubate. But don't do that, because that intubation itself can be life threatening. Very good point. And if you look at the situations that we talked about hypoxia, we talked about hypotension, right ventricular dysfunction, and metabolic acidosis. As these are the entities that constitute the physiologically difficult airway.
Yes, ma'am. What about you think, ma'am, like regarding awake intubation, we do it in anesthesia generally when there is a difficult airway, we do awake intubation and all. But in critically ill, it is a bit difficult. Do you think altogether, especially if there is the
See,
complexity of airway, anatomical difficulty with physiological difficulty, patient with trauma, with facial injuries, and aspirated blood and hypoxic, so become and hypotensive because of bleeding in somewhere else. This is a messy situation we do encounter sometimes. What do you think is the approach here?
it's a very, very good question. Okay. So I want to tell you that, awake intubation is very challenging in a critically ill patient. Okay. And you really need an expert. So
Yes.
I would recommend an awake intubation only for an anatomically difficult airway. If you have an anatomically difficult airway, go ahead and do an awake intubation, because you might actually lose the airway if you try to. So anatomical difficulty, get an expert, but, try to do an awake intubation. And again, when you do an awake intubation, like I said, you can use delayed sequence intubation. You can give ketamine to this patient, calm them down, pre-oxygenate them well. It'll facilitate flex, because, awake intubation as done in the operating room, you're giving local anesthetic, you're doing nebulization, you're doing all that preparation, you're giving blocks. All this is not possible in a critically ill patient. Patient is not going to cooperate. Patient is not going to allow you. Patient is not going to give you time. So, it is very theoretical that when you say do awake intubation. So, a good strategy, and what is done a lot in the emergency department, is again giving ketamine, 50 milligram ketamine, 1 cc of ketamine. And you can give this, patient becomes very calm, pre-oxygenate them well, keep your scope and everything ready. So if you're talking about awake intubation, it's not really awake, it's kind of little asleep, but you are, maintaining the hemodynamics, and you are also keeping the patient spontaneously breathing. The biggest worry about doing RSI and why people want to do awake is because they know that when you give drugs, there can be hypotension. They're worried about the hypotension, and they're worried about the desaturation after giving the muscle relaxant, right? So when you have a very fragile patient, who is, that I'll knock this guy off, he'll just arrest. Or, someone who's very, very, very fragile, and, that this is impending cardiac arrest. Those are the patients with a little ketamine, you can do an awake intubation. But it is challenging. It needs expertise. So
Challenging.
I would say the default should be rapid sequence intubation. A lot of physicians are very afraid to give muscle relaxant. Right? I want to emphasize this point, because they give little fentanyl, little midazolam, little. Actually, they make intubation more difficult. So you are making the conditions very difficult when you have less expertise. So it has been clearly shown that when you give a muscle relaxant, ventilation becomes easier, intubation becomes easier, everything becomes easier. So don't be afraid to do rapid sequence intubation. Data has, clearly shown that RSI is, far superior with first pass intubation success and reducing the complications related to airway management. You should have very good controlled, non-moving, non-distinct patient when you're doing that, especially when you have less skill.
Yeah.
Right. So, and always keep a supraglottic airway device next to you. Very few ICUs have a supraglottic airway device. Now, if I was a physician, I would keep that supraglottic airway device, because by chance I'm not able to intubate. Remember, not intubating will not kill a patient. Not ventilating will. So if you are not able to intubate, so what? Just put in the supraglottic airway device. And that's such an easy tool. The technicians are doing it nowadays. ED, you have it in ambulance, you have paramedics who are putting in a supraglottic. So I think every ICU should have a supraglottic airway device as a rescue in this kind of situation. So never be afraid to give the muscle relaxant is what I would say. Because I go to many ICUs and I see people giving midazolam, fentanyl, and they'll say, no, I will not give muscle relaxant because, if I lose the airway, they're very worried about this. But really, that practice should stop.
That is very important, a very practical point. I think one of our delegates, the audience asked, like, what is glottic impersonation? Can you kindly elaborate?
Yeah. I mean, this is described. There are case series of this. Okay, it's not that happened. So, especially when you use a direct laryngoscope and you're giving a lot of force, okay, during the laryngoscopy, which happens when you don't get a good view, you often get blanching of the, the tissues, and that gives a view like the vocal cords. It is known that people think that they saw it going through the cords. It's a entity called glottic impersonation, but actually you're going through the esophagus. Okay, it doesn't happen every time, but it is known. And also, there is, like I said, a lot of cognitive this thing, because you want to put the tube through the vocal cords. So you imagine and you see and you believe also that you put it through the cords. So, when a person says that I intubated the patient and I saw the tube going through the cords, the best thing is to put a video laryngoscope in. Like I told you, changes the view from me to we, and you can see what they can see. You confirm it immediately, right? So the point I'm trying to make is, don't go solely on someone telling you, I under vision put the tube through the vocal cords, okay? Because sometimes it's a little plus minus, right?
Yeah, yes, ma'am. There is one more question from Dr. Riaz. I think he asked, use of LMA as bridge to difficult airway, ma'am. Yeah. What he intends, role of intubation in anticipated airway.
Yeah, as a bridge, as in first put in the supraglottic airway device and then try to intubate that. Yeah, so that is a little complicated, to do that, because if you have to intubate, you can put in the supraglottic airway device first, and then you need a bronchoscope to intubate through that. Okay, so that becomes a little complicated to do and requires a lot of expertise. So unless it is really difficult, okay, and if it is really difficult, then you can consider anatomically difficult, then you can consider an awake intubation. But I would suggest that, if you never worry about a difficult airway, do RSI, give the muscle relaxant. Suppose you can't intubate the patient, okay? And you put in a supraglottic airway device and you can ventilate. Once you can ventilate the patient, don't worry. Go have a coffee. For 3 to 4 hours, you can manage the oxygenation with that supraglottic airway device. Or, instead of doing face mask ventilation, because your arms are going to ache, right? And then get an anesthesiologist, get someone who's an airway expert, and they will intubate through the supraglottic airway device. And remember, when you have a very, like you're saying, trauma, you said all that, people always think that you have to pass the tube. No, sometimes doing a tracheostomy under local is the safest option for that patient, because you have a Leffon's fracture, you are bleeding, you have, and remember, even when I say video laryngoscopy increases first pass intubation success, blood and secretions are the enemy for any of these techniques, video techniques. So even if you have a bronchoscope or you have a video laryngoscope, once the patient has blood and secretions in the airway, it is absolutely impossible to see anything. So sometimes, you need to tell the surgeon, just do a tracheostomy under local. That's the safest option for the patient. So don't hesitate. Every patient doesn't need a endotracheal tube. Like we are moving away from the era of heroics, that I was able to do this, to the era of safe airway management patient, because you cannot have a single mortality because of a loss of airway, right? So that's what we are moving towards. So we should do that. And I would say, do an RSI. If you don't succeed, put in a supraglottic airway device, which is technically very easy. The failure rate is very, very less. Use a second generation supraglottic airway device. Keep one supraglottic airway device in your kit in the ICU. You're not going to use it. And the reason we don't use supraglottic airway devices like we use in the operating room is because, it causes a lot of pharyngeal mucosal pressure. There's an inflated cuff. And so you can't use a supraglottic airway device for more than 4 to 6 hours. And that's and patients in ICU, they are on a ventilator, this is long-term intubation, and that is why we don't use it. But as a rescue, it is a perfect tool to have in ICU. When I walk into some ICUs where I go for inspection, they really don't have a supraglottic airway device. And that is a tool that can really save your day, especially if you have an airway crisis.
Yes. Yes, ma'am. Thank you. Thank you very much, ma'am. I think one last question, ma'am. Somebody asked retrograde intubation in ICU patients before tracheostomy. Does it require, like, does we practice?
So see, retrograde intubation was a technique that we used to use in the operating room when we didn't have flexible bronchoscope, right? Because it is a blind procedure and it needs patient cooperation. So the patient has to take, the epidural catheter is passed through here, the patient brings it out of the mouth, and then you railroad the tube. So that's a retrograde intubation. So, I don't see a critically ill patient cooperating for that. You need a lot of patient cooperation, okay? So, and the other reason is when you are in the area, when you have bronchoscopes and you have techniques that you can do under vision, then we should move away from blind intubation and retrograde. So that will be discouraged. Besides, it needs a lot of expertise, to do that, and patient cooperation.
Yes, ma'am. Yes, ma'am. Absolutely. I think there are a lot of comments, more than 155 people logged in, ma'am. Lot of comments. That's superb, excellent. I think learned so many things from this lecture. Very, very privileged to have you again on our platform, ma'am. Really outstanding. I could learn some practical points
Thank
very.
you.
Thank you very much, ma'am. It's nice interacting with you. Any final comments from you, ma'am?
Yeah, I just want to say and reiterate what the last line of my message actually is that tracheal intubation is a life-saving procedure, but this can turn into a life-threatening procedure unless it is managed carefully. So you must take all the precautions. Don't rush to intubate. Try to physiologically optimize the patient because this is a critically ill patient. So, and use all the tools to your advantage. Make sure that you have these tools in your intensive care unit. And use a bougie and a stillet during the first attempt. People don't do that. And put in a stillet, shape the tube like a J shape or a hockey stick shape. It'll make your, all these things like positioning and tools and these technical things make your intubation easier. You make it difficult by giving wrong position, by using the wrong tools. So you can make life much easier for your patient. And physiologically optimizing these patients prior can give you more reserve for the patients. And we have to move towards safer and safer intubation practices. You have so many times they try to intubate the patient and the patient had a cardiac arrest. Now, why did the patient have a cardiac arrest? That could have been avoided. So I wish you all a very safe airway and do remember all these points when you do your next tracheal intubation in the intensive care.
Sure.
I'm happy
Very.
to share the paper. I can send it to you,
Yeah,
Kala.
send it to me, ma'am. I will send it across to all the delegates.
Especially those who are exam going, it covers, I couldn't cover many things in detail. It covers every aspect of airway management in the ICU. And you have all the updated references, the cross references which you could refer to. Yeah.
Sure, ma'am. Sure, ma'am. Thank you very much, ma'am. Thank you, ma'am. Very good night, ma'am.
Thank you. Thank you
Thank
so much. Thank you for inviting me. Thanks.